Hello, welcome to Dr. Jeff Talks About Sex and Intimacy. I'm normally your host, Dr. Jeff Albaugh, but tonight, my dear friend and colleague, Dr. Susan Kellogg-Spadt, will be stepping in as our guest host. I know, try not to fall over from the shock, but I'm actually taking a little time at the beach, earthing, grounding, and trying to thaw out from the cold Chicago winter. Whether you're joining us live or listening later on with this recording, thank you. Truly, I am deeply grateful for each and every one of our listeners. Your presence and your engagement are what make this community so meaningful. So thank you. We're all over social media. We're on Facebook, we're on YouTube, we're on X, we're on LinkedIn. If you're watching on X and you want to ask a question, hop over to YouTube, LinkedIn, Facebook, or StreamYard so you can ask those important questions. And if you're on Facebook, please, we'd love you to follow us. The more followers we have, the more we can do. And so we really appreciate if you follow us on Facebook. You can also visit our website to learn more about upcoming episodes and catch up on the past ones. And remember, you can listen to us wherever you are on Spotify, on Amazon, iHeartMusic, Amazon Music. Wherever you are, we're there with you. So whatever your favorite streaming platform is, listen to us there. Most importantly, I want to remind you, as I always do, that all are welcome. Whatever your sexual orientation, your gender identity, or your relationship style, this space is for everyone. What's the goal of the podcast? It's pretty simple. It's to empower and enlighten you with the evidence-based information you need that supports your sexual health, that deepens your relationships, and helps you live your one miraculous, wholehearted life.
Hi, I'm Susan Kellogg-Spadt, and I'm going to be your guest hostess tonight. It is my pleasure to welcome all of you today, and it's really my pleasure to talk tonight with an expert in pelvic medicine about the role of the pelvic floor in orgasm and orgasm difficulties for women. I'd like to introduce you to Kelly Keane. This is a physical therapist. She's a physical therapist at the University of Pennsylvania, the finest institution in the Philadelphia area. She has been a physical therapist for 24 years, but just 17 years ago, when she had her own child, the birth of her child, she realized that her true passion was working with the pelvic floor. The miraculous job that the pelvic floor does when a woman has a baby blows your mind, basically. But it's such an important part of a woman's body. And so Kelly has literally devoted her entire career to helping women and empowering women to understand the role of their pelvic floor with things that have to do with sexuality, defecation, urination, walking, structure, everything about the pelvic floor. But tonight, we're going to talk to Kelly about the role of the pelvic floor muscles and sexual dysfunction, specifically orgasm dysfunction in women. So with that, we'll take it away, Kelly.
Well, hello, good evening, and thank you so much for that welcome. I'm very excited to be here tonight and talk about some orgasms and pelvic floors. All right, so we're going to start off with talking about the role of the pelvic floor muscles in orgasm. So the basics of the pelvic floor are that they sit kind of right at the bottom of our bony pelvis, and they kind of act like a hammock, supporting the contents of the abdomen, and they can also act like a doorway that keeps urine, poop, and farts in, or it can open them to let them out. Importantly, the clitoris is so much larger than we can see from the outside, right? And this is something that a lot of us aren't very educated in, and we're not very familiar with. So sometimes it can be a little bit difficult to figure out how we can move, how we can interact with our clitoris in ways that really feel good and are not overstimulating. So basically, the clitoris that we see from the outside is just the tip of it. There are two arms of the clitoris that go downwards. So if you think about the clitoris kind of being right here at the tip, the two arms of the clitoris kind of go down along the edges of the vaginal canal. When we start to get aroused, it causes the muscles of the pelvic floor to kind of contract and relax rhythmically. And this speeds up progressing us towards orgasm. So it's actually an important thing to be able to move from just an arousal state, because that feels good, to the actual release of orgasm. So when we start in early arousal, this kind of signals the body to kind of slow down, to rest, and basically to engorge, to get larger. The pelvic floor muscles kind of show a little bit of very gentle but sustained activation. And as we kind of keep getting more and more aroused, those signals kind of loop through the spinal cord itself. This bypasses the brain. So hopefully we're able to get out of our own brain, out of our head, and we can allow our body to have that smooth rhythmic contraction and relaxation that generally speeds up. So the longer that arousal goes on, we have less voluntary control. And then right before we reach orgasm, the brain kind of reduces the inhibitory control. So it kind of takes the brakes off. That loop through the spine intensifies, and we get faster, rapid, automatic contraction. And then during orgasm itself, the pelvic floor muscle contractions speed up a lot. They get to less than a second apart. We release all those feel-good neurochemicals, and orgasm actually occurs. And this is a hardwired motor reflex that's very similar to a sneeze. Unfortunately, though, sometimes just like a sneeze where we can kind of stifle it, sometimes our orgasm can be stifled as well. So then how does the pelvic floor kind of interact, and what role does it play in orgasm? There are basically two ends of the spectrum that can really impact orgasm. So if we have tight pelvic floor muscles, it could cause pain. So if the pelvic floor muscles are too tight to allow the penis or anything else that's going in there easy entry, it takes us right back into our brain. It moves us out of our body into our brain, and our muscles tense to protect us. It can block the speed transition so that we don't accelerate towards orgasm, or it can prevent the reflexic release. And then the opposite problem is that if we have weak or uncoordinated pelvic floor muscles, they're not kind of pressing on the clitoris. They're not stimulating, they're not allowing stimulation of the nerve to be intense enough to really progress arousal. And so that can either delay or weaken or not allow arousal and eventual climax.
But if they're too loose, it can inhibit orgasm as well.
Yes, if they're too loose, we cannot get enough stimulation to really push us towards orgasm.
Okay. So when I send a patient to you for physical therapy because they're having difficulty with orgasm, maybe there's all kinds of patients that would benefit from going to a physical therapist. But in this space, there's patients who've never had an orgasm in their whole life. That's about 10% of all women, by the way. But there's another cadre of patients that either don't think that they have orgasm more easily enough, number one, as easy as they could when they were 20, number two. Number three, can't have an orgasm after surgery or after an injury, number four. Can't have an orgasm after menopause. There's the M word. Yes. And the other one is they just don't think they have them enough. They have them and they're great, but they're kind of like, they're not as standard as the bus coming on the corner every 15 minutes. It's like, they're like, what happened this week? I don't know what happened this week. There was no O this week. So anyway, so there's all the different kinds of patients. My question to you is, when they make it from my office to your office, what do they expect? What are they going to feel, see? Is it going to be scary? Are they going to be naked in front of a whole bunch of other patients who are also naked? Talk to me about this.
Sure. So the experience in pelvic floor is pretty similar kind of across the board. We're all trained fairly extensively, and we're trained to prioritize people's comfort and feeling of safety. So in mine and every other pelvic floor therapist that I've worked with office, it is a one-on-one office. So in my space, I have my treatment room and some decorations to try and make it feel warm and welcoming and inviting. And the vast majority of what we do that first session is just talk. We talk about what symptoms somebody's having, because nothing in the body works alone. And especially with the pelvic floor, if one thing's going wrong, there's very likely to be more than one symptom. So we're very likely to have things like, well, I'm leaking a little bit too, or I'm having trouble getting poop out of my body. And so that can kind of clue us in and let us know what we need to work on. So a lot of talking, a lot of questions about what things used to be like, what they're like now, any other symptoms. We also will kind of check in on what other things might be going on in someone's body, like low back pain or hip pain. We will always kind of talk about, like, what are your goals for treatment? What do you want to get out of this? Because that tends to be really, really important. Because my goals for somebody, I really want to make sure that they are right along with what the patient wants to get out of this. And so we'll talk about goals. We'll talk about all the different things that we might treat, all the different ways that we can help you. And then eventually, for me, to be honest, I talk a lot with my patients, and I really like to get a really thorough background and, frankly, to make them feel comfortable. So a lot of times, personally, I don't get all the way to an internal examination on that first day. Sometimes I can, but a lot of times it's a follow-up exam. And at that point, I always tell people, no offense, Dr. Kellogg, but I always tell my patients that my pelvic floor exams are probably going to be the best one they've ever had.
Yeah, probably.
Because the privilege of pelvic floor physical therapy is that I don't need to get an answer in one moment. We can take time. If somebody is at all uncomfortable, I don't need to sort of see and assess the cervix right now to get an answer to know what step to take next. So we make sure that patients don't feel any discomfort if we can at all prevent it. So did I answer it thoroughly? I was trying.
You did. But here's my question. I'm in physical therapy right now for my knee. And when I go to physical therapy, I'm in a really big room,
Huge
right
gym.
next to somebody else and right next to somebody else who are all getting different body parts working. So if I go to pelvic floor PT, am I going to be a big room next to everybody else who's in there like underwear?
Never. I have never even seen pelvic floor therapy treated kind of behind a curtain, like sometimes they'll do in big gym spaces to give that little bit of privacy. In fact, I started a pelvic floor program when I first got into pelvic health 17 years ago. And at the time, our big gym only had the privacy curtains. And I came back from my first course and I went right to my boss and I said, listen, I'm not doing it unless you get me walls and a door. So it is always in a private space. Sometimes there's like music and mood lighting. That kind of depends on the therapist and the environment. But yet always privacy. You're generally never going to be at all exposed with other patients. Now, sometimes if we're progressing therapeutic exercise, we might go out and join people in the gym, but always fully clothed.
Okay, so it's really private. It's one-on-one. It starts out with talking. This is sounding really safe and not scary.
That's the goal.
So because we're talking today about orgasm as it relates to the pelvic floor, in this space, do you see all, mostly women under 30, mostly women over 60, or give me the demographics here?
I have seen women and men, frankly, because we treat men as well, but of all ages. I've seen young women in their teens who have pain with tampon use. And so they're like, how am I possibly going to have sex if I can't get a tampon in there? So we can start very, very young. And, I've learned to never underestimate the willingness and the power of people that are older than me to have sex. I remember getting schooled I think she was probably in her late 80s. And I was talking about, I was like, so are you currently having intercourse? Because we talk about intercourse and pain as it relates to the pelvic floor. And she looks at me, she's like, of course I am, all the time. And I was like, that's amazing. Life goals. So yeah, absolutely. We cover across the lifespan.
Okay. So here's my next question. If the patient doesn't have any pain in the pelvic floor, like they feel lovely, but they just can't have an orgasm no matter how, whether it's direct clitoral stim or, something in their vagina, kind of where do you all start with helping them to work their way toward orgasm?
So we talk about expectations for orgasm. We talk about past history. We've talked about what things they've tried. And then we'll go to the assessment. We'll see if there's any sort of physical changes that might be contributing to their difficulty with arousal or orgasm.
Mm-hmm. And do you think that this is, how do I put this? Do you think this is always a mind-body connection? Is the mind always on board with this? And can it be to your worst enemy on this one, I guess is what I'm trying to say.
So unfortunately, very much our mind can be our absolute worst enemy, because if we can't allow our brain to enter a space where it feels safe and calm, or where it's not worrying about when do I need to pick up the kids? Is the baby going to cry right now? Am I going to get interrupted? If we can't take ourselves out of that space, then it can be very difficult to achieve orgasm. So, I'm not a therapist or a sex therapist. I'm not a psychologist, but there's so much interplay between the brain and the body that we really kind of talk, and we can take some time to explore that through our sessions.
You know what I thought was so interesting is when you were talking about the physiology of orgasm, you said at this point, the brain has to kind of quiet down and allow for the sensations to come through. And I was thinking, if you're or whatever, a patient sitting there going, oh God, I hope I can do it. I hope I can do it. I hope I can do it. Am I being judged? Am I being judged? I really want this. I really want this. That's going to absolutely short circuit the orgasm. Would you agree?
Oh, 100%. It's almost like the more you want to get there and the more you're in your head about getting there, sometimes the more elusive it can be. Sometimes the conversations that I have with patients are, for so many of us, a good, in quotes, sexual experience requires orgasm. When in fact, orgasms are nice. Don't get me wrong, but there can be a lot of intimacy that's connected with states of arousal and with all different kinds of sort of sex and intimacy that doesn't require arousal. So the more pressure we get, it doesn't require climax. So the more pressure we mentally put on ourselves, it is very frequent that reduces our ability to actually relax enough to reach orgasm.
So maybe to distill this, if a person who's working with you and with me, and they're working toward improving their orgasmic life, if they would maybe not expect an orgasm as they're on the road to orgasm, just don't expect it at all. Just expect relaxation and letting the pleasure happen, or feeling pleasure rather than pain. But that's it. That's the sum total of the experience expectations. Am I right?
Yeah. And if they can, the more they get into the sensation itself and the fact that the sensation feels good, because for most people, arousal feels great. And the more we can get into our body and really experience those pleasurable sensations, it's almost like climax will kind of slip in a little bit easier just because you're not paying attention to it. So yeah, sometimes we really sort of focus on our breathing and our muscle tension and really kind of get out of the space of trying to have a climax. Absolutely.
Okay. So what would you say to a woman who can easily have an orgasm with herself through self-pleasuring and masturbation, but for all the tea in China, she can't have an orgasm, either external stim with her partner or internal penetration with her partner?
Well, I would say that, first of all, she's not alone, because there are a lot of people that find it much more easy to to get themselves there than to have somebody else get them there. The other thing that I really want to make sure that the patients that I work with know is that so many women, a larger percentage of women, cannot reach orgasm through vaginal canal stimulation alone. A lot of women need at least a little bit of clitoral stimulation to achieve orgasm. And I kind of, not to bring it to too base of a line, but one of the things that I frequently talk with patients about is kind of like, the vaginal canal feels really good for a penis, and the clitoris feels really good for us in our body. So a lot of women really share that experience. And so we will talk about, how do you talk to your partner about what feels good for you? How long have you been, masturbating the same way? Because our brain gets really, really used to kind of getting from point A to point B very quickly when we know exactly how to move. And so if somebody's moving in a way that doesn't really match what our history is and the way we kind of interact with ourselves, then it can be really hard for our brain to sort of say, oh, I'm supposed to orgasm next. Okay. And so we'll have conversations about things like mutual masturbation. Has your partner ever watched you masturbate so they can get a sense of what you do to yourself that they might be able to replicate? We talk about, basically, when did you start orgasming? Or excuse me, when did you start masturbating, right? Under what circumstances did you start? Because if we started when we were young and we were trying to get it done really quickly so nobody would walk in the room on us, a lot of times we're going to sort of either reach orgasm really, really quickly, or we're not going to be able to reach orgasm because our brain is sort of set up to expect this really fast, really rapid progression to orgasm, because that's how we trained our brain to respond to stimulation. The other thing I talk about with patients is, there are some really cool toys that are out there that are like, vibrators that are designed to wrap around the base of a man's penis or anything else that's going inside, that can kind of provide that clitoral stimulation in addition to the stimulation of the vaginal canal.
Okay, so is it normal for a woman to have orgasm capability change across her lifespan?
Unfortunately, yes.
Okay.
I was just talking with a patient about this, that, when we're in our mid-20s or early, it seems like it's so easy. We have much higher levels of lubrication with arousal. And then, that M word, menopause and perimenopause, we get hormonal changes that absolutely impact the pelvic floor and impact the pelvic floor function. And so all of a sudden we kind of can't get there anymore. This is unfortunately really, really common. And the other thing that's really common is that people who have never experienced pain with intimacy before get enough of hormonal changes that it starts to irritate and cause pain where it didn't before. And so quite frankly, if the last time I tried something, it hurt, I'm not really going to get myself in the mood to get hurt again. And so a lot of women will sort of start cutting off those early signs of intimacy from their partner because they don't want to kind of be a tease, if you'll forgive me. They don't want to sort of, if it was painful last time and I don't want to have that pain again, then we sort of tend to remove ourselves from the things that will set us up for that pain. So, that kind of rubbing of the back while you're in the middle of doing dishes that leads to the kissing that leads to the everything else. Well, as soon as you touch it, you're like, back off. Like, what are you, leave me alone. Can you go take care of the kids or whatever? And so there's a lot of factors that absolutely change. And, my rule with my patients is sex is not supposed to hurt ever. Sex is supposed to be good. And so that's absolutely a reason to come see someone like yourself and someone like myself to get back to sex feeling good.
So you brought up a point, and that's that every sexual scenario doesn't have to end in orgasm. And maybe taking the pressure off to orgasm would actually be good for us to just really enjoy, to enjoy the sundae without the cherry on top, as it were. really enjoy the ice cream, to feel the ice cream in the mouth, to, oh my goodness, this tastes so nice, and not necessarily get to the ending. And I think we've all been socialized in that sex has a beginning, a middle, and an end. And Jeff would be, if Jeff were here right now, which he's probably watching, he's probably going, right, go for it, because he cannot stand the fact that people see it in such a kind of a very small way, you know, like it always has to happen in a bedroom. It always has to happen in this way. And it always has to end in orgasm. Now, there is a little bit of a difference. I think you'd agree with me that sometimes the experience ends in orgasm more frequently for men than it does for women.
Very much. Yes.
And so I think kind of, can we give women the okay to not have an orgasm every time, and that's kind of a normal way to unwind. Do you remember when I said that 10% of women never have an orgasm? Well, here's a more astonishing one, and I think we can all pretty much relate to the 60% of women wish they could orgasm more reliably or more often. And that's across the lifespan. So,
absolutely.
So never feel alone if you're having trouble with orgasms. Never.
Absolutely.
So, okay, now let's get down and dirty. Let's talk about, okay, I've had my first session with you. I feel like I trust you. I know I'm going to be in a room behind a door and I'm going to be safe, and I'll be draped with a drape sheet. But my understanding is, and as your patient, that probably we're going to move on to where you're going to do some external work on my muscles, but also internal work in my muscles.
Absolutely.
You're also going to give me some homework assignments, I think. So can we talk a little bit about what does a session look like and what does homework look like?
Absolutely. So for my overarching, what I want everybody to pay attention to, because frankly, every single one of us needs to pay attention to, it all comes down to breathing. So what we don't necessarily do anymore is stand up straight with nice posture. We don't sit with nice posture. We go to kindergarten, we kind of slump forward like that. And we spend the whole rest of our, up to our 20s sometimes in a chair slumped over. And then we get into the real world. And there's still no place for us to really have good upright posture. And so what ends up happening is our diaphragm, which should be able to drop a couple of inches into our abdomen, gets jammed up into our guts. And so I always start an assessment with, show me how you do a big belly breath, right? And I tend to do a lot of manual therapy throughout the abdomen, because there's a lot of tension that's related between the abdomen and the pelvic floor. I tell people we have connective tissue that's kind of like Spider-Man's costume, and if Spider-Man were to be grabbed by the bad guy right in the tummy, and the bad guy kind of picks him up and says, Spider-Man, right? Where's Spider-Man going to feel that first? Right in the crotch. He's going to go on his toes and start singing soprano. And so we'll do some work through the stomach, which kind of feels like somebody kind of rubbing your belly in a lot of my early sessions with people. And then again, we do that internal assessment and we figure out exactly what's happening, because unfortunately for a lot of people, we don't know when our pelvic floor muscles are too short and too tight. And because they can kind of give us a lot of similar symptoms being totally disparate. Right? So if my pelvic floor muscles are too tight, I might pee when I sneeze because they're already engaged. They can't give any more if they're already really engaged. Mm-hmm. Or I'm going to leak because my pelvic floor muscles are weak and they just can't support it enough. Right? So those, just the symptoms alone aren't really going to tell us what's going on inside. And so when we do the internal assessment, we kind of feel the muscle, we feel how much flexibility and mobility it has. And then we make sure that people know how to move their muscles correctly, that they're coordinated. And then for me, homework looks a lot like, well, it sort of depends on what we found. If someone, when someone shows me that they can't breathe well, then we prioritize that. Because if you think about the fact that the diaphragm's up here, and then we've got the guts, and then we've got the pelvic floor at the bottom, if the diaphragm drops, it compresses the guts, the pelvic floor drops. So when we exhale, it goes up. When we inhale, it goes down. And so the pelvic floor muscles should be functioning like this throughout the day, keeping us mobile. And when they can't, when they're too short and tight, I kind of tell people that it's sort of like if you're sitting in the back seat of a car right? My husband has a Fiat 500 Pop. It's this like little teeny tiny car. And so sitting in the back of it is horrible. Your knees are around your elbows and you just feel stiff in it. And what you need to do is move, right? And so if our pelvic floor is stiff, we need to move it, right? If our pelvic floor is weak, we also need to move it. We need to squeeze it, right? I always tell people, my favorite cue to get people to do a pelvic floor muscle contraction correctly is if you think of a claw machine, right? That game at the store that my son always wants me to let him play, that kind of grabs the toy and pulls up.
Mhm.
Well, that's what our pelvic floor needs to do. Our vagina kind of closes and lifts up towards our head.
Yep.
So I tell people, imagine that your vagina was a claw machine and you were trying to pick up toys. And so very similar to the way that somebody with really tight shoulders or a lot of tension that they're carrying through their
Right.
straps,
Mhm.
what we might say, hey, listen, I want you to move. I need you to stretch yourself throughout the day. So we might teach them to kind of do big shoulder rolls, get some mobility going. We can do the same thing with the pelvic floor. So I try to get people in terms of homework to think about what isn't happening correctly in my body. If I'm too stiff, I need to move more. If I'm weak, I need to make myself stronger. And so I personally like to realize that most of the people that I work with have lives a lot like me. Right now, as we're talking, it's about 8:30 at night, and I've been at work since about 8:45 this morning. And so if you told me I need you to sit down on a table or lay down on the floor and do 20 to 30 minutes of exercise, I would not be able to do that consistently through my week. I might be able to do that a couple of times. And so with my patients, I really like to try, and I think it's kind of across the board. We try and give things that are really functional that you can do really frequently throughout your day. And especially because our pelvic floor muscles are part of our posture. Right. And so if somebody comes in and they've got poor posture, I'm not going to say, well, can you sit up straight? Cool. You sat up straight. Now your posture is fine. Right.
Mhm.
No, because immediately we go back into that slumped position. And so if our pelvic floor muscle is too tight and we're trying to do that breathing and we do it once and we get our pelvic floor muscles to relax and that's doing great, and then we keep moving through our day, our pelvic floor muscles are going to get tight because that's where they know where to set. And so a lot of very easy, quite frankly, anyone can sit and do pelvic floor muscle exercises in just about any position, because I always tell people you got to do it like a ninja. You got to be able to have somebody looking right at you and be doing these movements, because our pelvic floor should be that independent.
Okay.
Sometimes if someone needs it, we kind of go more into, I'm going to need you to lay down and this is how we're going to move your hips, or we're going to strengthen, because there's a whole lot of coordination that goes on between the core muscles, the hips. So sometimes we do sort of more kind of traditional PT exercises as well. But a lot of it comes down to the small things that we can do really frequently through our day.
That sounds amazing. I can't tell you how many patients believe that the thing that they learn most in PT and the thing that they learn most to help them become orgasmic was breathing. It was really learning how to breathe, to relax their shoulders, relax their body, and fill their lungs with air and drop that diaphragm. So I'm so glad you brought that up, because people think about, oh, I'm going to go to pelvic PT and they're going to have me using, and not that you don't, people use dilators and vibrators and things, but to learn how to breathe is one of the greatest gifts you can ever give anyone. So it's really great.
Yeah. And not only that, but a lot of times, one of the things that happens as we progress towards orgasm is we tend to get kind of caught up here in our chest. And we're getting so close and we forget to breathe. And then everything stiffens up and we can't do that nice rhythmic less than 1 second contraction to sort of cross that bridge into orgasm. So a lot of times we do talk about focusing on the breath while we're feeling these good sensations, and just breathing better can sometimes help move us more into orgasm.
That's great. Well, boy, this time has gone so fast. I can't believe how I never get tired of talking about orgasms, and I'm sure
Me neither.
But I've learned so much from you, and I want to thank you so much, very, very much. And Vic, can we just say a quick hi to Jeff and see what he has to say about next week?
Hi, Jeff.
Before we close today's episode, I want to invite you to take a moment to breathe with me. Sexual health can bring up feelings, fear, shame, relief, curiosity, or even empowerment. Whatever you're feeling, it is welcome here. Take a slow, gentle breath in and let it go. Place your hand over your heart, or you can place your hands over your abdomen, either way, wherever feels comfortable. Continue that breathing pattern in your nose and out your mouth. As you breathe, imagine a quiet, steady light growing beneath your hand. This is your inner wisdom, your ability to care for yourself, to ask questions, to seek clarity, to choose safety, and to show up with courage, compassion in your intimate life. Breathe in. I deserve knowledge. I deserve knowledge. Breathe in and breathe out. I deserve safety. I deserve safety. Breathe in, and as you breathe out, I deserve pleasure. I deserve pleasure. Breathe in, and as you breathe out, I deserve healthy connection. I deserve healthy connection. Let one more deep breath flow in and out. When you're ready, gently return to the room around you, knowing that your sexual well-being is an essential part of your whole person, and you are worthy of care, of honesty, and of joy. You are miraculous. Vic, what's up next week on Dr. Jeff Talks About Sex and Intimacy?
In this insightful episode, Dr. Jeff breaks down the 5 love languages. Words of affirmation, acts of service, receiving gifts, quality time, and physical touch. He explores how understanding these simple yet powerful concepts can transform the way couples connect. Dr. Jeff explains how mismatched love languages can lead to confusion, resentment, or disconnect. He also discusses how learning to speak your partner's language can foster closeness, trust, and a more fulfilling sex and intimacy life. Join us on February 17th at 7 p.m. Central Time to learn more.
Oh, that sounds good. Pretty exciting.
Definitely.
Well, our final words to you are, Dr. Jeff just said you deserve honesty, you deserve breath. Well, I think you deserve orgasm myself. So those are our final words to you. Kelly, can you help our listeners find physical therapists in their area?
Absolutely. There's one of the number one resources that you can look at is the American Physical Therapy Association. So it's apta.com, and you can search for a pelvic floor physical therapist. You can search using your
Zip code.
Yeah, words were just not coming. You can search using your zip code so you can find someone in your area.
Great. Well, everybody, thanks for joining us tonight. A special thanks to Kelly Keane, who is the expert in the pelvic floor, helping women have orgasms one pelvic floor contraction at a time. And feel free to tune in to Dr. Jeff Sex Talk for all of the great topics that we talk about through the year. Thanks for coming tonight and joining us.
So much.
Dr. Jeff talks about sex